All right. Good morning or good afternoon, everyone, depending on where you're joining us from. My name is Sukirtha Tharmalingam. I'm a senior manager of evaluation methods here at Canada Health InfoWay, and it is an absolute pleasure to connect with all of you virtually today on our Benefit Evaluation Collaboration Network. I'm very excited to see the attendees number creeping up as I'm starting here. Very excited that you're all interested in this topic. We're excited. InfoWay and our partners in the healthcare system have been on the journey towards interoperability and the ability for data to flow seamlessly across the healthcare continuum, ensuring that different parts of our healthcare system can consistently and securely share data, and with the ultimate goal of connected care for Canadians. And that's what we're focusing on today in our webinar. We've been engaged in some research recently to support this work, and we're very excited to be able to share that today with all of you. So I'll do a couple of housekeeping notes, and then I'm going to pass it over to our exciting panelists that are here. So, as I said, I've got a couple of housekeeping notes, and then we'll jump right into the findings that we're very excited to share. And as usual, we're going to save the Q&A for the end of the presentation. But I do encourage you, as things come up for you or questions that you're thinking about as we're going through, type them into the Q&A box. And what I'll do is I'll moderate the discussion at the end of when we've gone through the presentation of results. So jumping right into our first agenda item, which is me, a couple of quick notes. If you're new to our webinar today, huge welcome. And if you're returning again, thank you for continuing to participate in this webinar. And this InfoWay's Benefit Evaluation Collaboration Network has been gone through a journey. We're continuously growing. And the goal of this webinar is to bring all of us like-minded folks interested in digital health evaluation, share best practices, share results and insights, and learn from each other. And we're always looking for others, looking to increase our membership. So if you want to join, if you're not already on our membership list, I encourage you to contact us at evaluation@infoway. And if you've got things that you're working on and this might be a platform where you want to share those findings related to digital health evaluation, I encourage you to also get in touch with us. And a note that today's webinar will be recorded, and the recording will be made available to those of you that are attending, and it'll be available through our website as well. So I want to do a huge welcome to our panelists that are here. So first, we've got Stephanie Lander, who's a Senior Research Director at Leger, and she's going to be presenting along with Waldo Beausejour, who's my colleague here at InfoWay. He's a senior analyst in the performance analytics team. A little bit about Stephanie. She's the senior research director on healthcare insights team at Leger, the largest Canadian-owned market research and analytics company. Stephanie joined Leger in 2016 after graduating from the research analyst postgraduate program at Georgian College, and she specializes in healthcare quantitative research studies and has extensive experience in studies related to digital healthcare. Stephanie graduated from the Media, Information, and Technoculture Honors Specialization program at the University of Western Ontario with a minor in sociology. Welcome, Stephanie, and thank you for joining us. I've also got here Waldo, who's a senior analyst in the performance analytics team at Canada Health InfoWay. He's led a variety of projects, including digital health equity analysis, the National Virtual Care COVID-19 tracking surveys, the quantitative analysis of the environmental and financial benefits of virtual care, and the 2020 National Survey of Canadian Nurses. You've probably met Waldo at a few of these webinars before. He's a regular here. Waldo's got extensive experience in conducting impact evaluations aimed at assessing the effects of government-funded initiatives on health outcomes. Waldo has a master's degree in applied economics and a strong background in statistics. So welcome to both of you. And now I'm going to turn it over to Waldo to kick things off. And I'll be back at Q&A time.
Thank you, Sukirtha. Thanks everyone for taking the time to join our webinar today. My name is Waldo Boseju, and as Securitas mentioned, I am a senior analyst at Infoway. I am a quantitative economist. And in terms of my portfolio at Infoway, I've collaborated on several projects, notably the 2020 National Survey of Canadian Nurses, the Digital Health Equity Analysis, the Digital Health Literacy Analysis, the environmental and financial benefits of virtual care, and also the Canadians' healthcare experience and uptake of virtual care during the COVID-19 pandemic, which was a longitudinal survey. And the most recent project was, the most recent project is the Clinician survey on interoperability that we are about to present you. Now, in a nutshell, I'm the kind of guy that likes getting his hands dirty with data. And just to prove you that, throughout this presentation, I will be asking some polling questions. The main purpose of this question will be to get to know you a bit, right? Or to prime you for some of the findings and to collect data, which is obvious because I'm a data analyst. But more importantly, this webinar will be, these questions will allow you to get a better webinar experience to make it more enjoyable, participatory, and interactive. So through these questions, we will build our knowledge on interoperability together. That being said, the first question is about knowledge of interoperability. So I'll launch the poll and I'll give you, so the first question, as I mentioned, is what best describes your knowledge? What best describes your knowledge of interoperability? So I'll give you 10 seconds to answer. Wow, I like data. I think we are still getting some answers. Excellent, excellent. Now the results. For the results, as you can see, we have the majority of our audience said they are knowledgeable about interoperability, and they are actively working on improving interoperability in the healthcare system. 47%. That's a beautiful number. And for those, and I think for those who fall in this category, I hope you will find this, you will take advantage of this webinar. It will probably allow you to strengthen your knowledge of interoperability. For the second category, we have 25%. 25% of our audience said that they are knowledgeable about interoperability, but not directly working on initiatives related to interoperability, which is not bad. But for the last two categories, where we have roughly 29%, those who said, I'm aware of it, but don't have enough knowledge on the topic, or never really heard of it. For these two categories, I would say you will find this webinar very informative, and it is going to be informative. So I will stop sharing the results, and then I will pass it over to Stephanie that will present the study objectives and the methodology that we use to generate the results for the survey.
Thank you, Security and Waldo. I'm really happy to be here today joining for the webinar, and looking forward to sharing some of the results of this research. So as Sukeertha mentioned, my name is Stephanie. I'm a senior research director on the healthcare team at Leger, which is the largest Canadian-owned market research and analytics company. So I'll be taking you through the results of the recent study we did among clinicians. But before we get into the results, we wanted to just quickly touch on the research objectives to give a bit more context. So the purpose of the study was to generate insights on the current state of interoperability across healthcare settings in Canada. So we looked to assess the need for improved interoperability, as well as to identify any existing gaps. We also wanted to see, are there any differences in the experiences and challenges when it comes to certain clinician types and care settings? We also wanted to gauge clinicians' workflows and the exchange of patient information, as well as assess what they see as being the key drivers and barriers. So essentially, what's motivating clinicians to improve interoperability and what's preventing them from doing so. And lastly, we were looking to identify capabilities and opportunities to further improve the exchange of patient information. All right, so now we'll get into the methodology. So it was an online survey. It was 10 to 15 minutes in length and offered in both English and French. Fieldwork took place from April 11th to the 28th of this year. And in order to qualify to participate in the study, clinicians had to say that they are providing direct patient care, and they must also be receiving and sending clinical information to and from providers outside of their practice for the care of their patients. So in terms of our sample, which was recruited from clinician panels, we had 818 clinicians participate, including 206 GPs, 201 specialists from various therapeutic backgrounds, 160 nurses, and 251 allied health professionals who we'll be referring to as AHPs for the webinar. So within the AHP sample, we had a really good mix, trying to get as many types of AHPs as possible. So we had a variety, including occupational therapists, dentists, dietitians, pharmacists, physiotherapists, among many others that were included. For the survey, we asked respondents to think of their main practice setting when answering questions, as of course we know that some do work in multiple settings. So our sample consisted of 3 quarters who mainly work in community setting and a quarter who primarily work in hospital. And as you may expect, we did find that the GP and AHP sample were more likely to be in the community settings, while nurses and specialists were comparatively more likely than GPs and AHPs to be working in hospital. And now within each of these clinician types, so within the GP sample, within the specialist sample, and so on, we did reach a regionally representative sample. And data was weighted by region within each specialty based on the latest CIHI clinician population data to ensure that we did have a representative sample. We also aimed for a good mix by demographics. So as you can see, in terms of gender, just over half, 55% were men and 44% were women. The average age was reported to be 44 years. And as you can see, we also had a really good mix in terms of the age ranges. So we had 17% being under the age of 35, over a third between 35 to 44, 1 in 5 between 45 to 54, and 18% being 55 or older. So we had a really good representation by clinician type, region, and demographics in our sample.
Now that you have an idea of how we generated the survey results, the next 2 polling questions will be about your experience of a lack of information sharing amongst healthcare providers, or if you will, a lack of interoperability. So I will launch the first question. Question number 2. For question number 2, have you or a family member had a gap in the coordination of needed care due to a lack of information sharing amongst your healthcare providers? Yes or no? I'll give you 10 seconds to answer this question. Okay. The results are in. So the yeses outnumber the no's. So we have 81% of our audience, 81% of people have experienced the problem we described in the in the polling question. Now let's move to another polling question. And this question, again, is about your experience of a lack of interoperability. So I'm launching the question. Question number 3, have you or a family member had an experience where you had to repeat a lab or diagnostic testing because your healthcare provider couldn't locate your recent results? Yes or no? Okay, I think I'll stop the polling and then share the results. The results are in. Unlike the previous question, for the previous question, if you recall, we had 81% for the yeses. Now we have, for the no's, we have 64%. So 64% of our audience have had this experience, meaning that they had to repeat a lab or diagnose. They didn't have this experience to repeat a lab or diagnostic testing because of a healthcare provider, because the healthcare provider couldn't locate their results. Now, I will stop sharing. Now, the questions that I would like to ask, and they are not polling questions. They are simple questions, and they are, I mean, first of all, what is the current state of interoperability in Canada? We often hear the terms digitization, digital transformation, you name it. Now, if we were to put evidence or to add evidence to this question, I mean, the first question we would ask is, what is the proportion of clinicians that are practicing or operating in a digital environment? Can they access the key patient information they need in order to provide care? Where do they access the information? Is it within their practice or outside their practice? And how do they receive patient information from external systems? These are some of the questions that Stephanie will address throughout, for the remaining of the presentation, and she will be using the results from the clinician survey. But before I pass it over to Stephanie, I know Sukirta mentioned at the very beginning the definition of interoperability. I just want to remind you of the definition that we use when we launched the clinician survey. So interoperability refers to the seamless exchange or sharing of specific patient information between healthcare providers across care settings. And some scholars, they said interoperability is about 3 C's: connection, collaboration, and communication. And other scholars, they even use the term data liquidity to refer to interoperability. And by that, they mean the ability for data to move around or to flow from one level to another. I won't say more. I will pass it over to Stephanie. Stephanie, the floor is yours.
Thank you, Aldo. All right, so we'll start going through the results of the survey. So first, we wanted to assess the use of electronic records among clinicians. A key aspect of improving interoperability is ensuring that clinicians are using technology that can most efficiently record, access, and share patient information. So it was important to understand the extent that electronic records are being used in practice and across care settings. As you can see, we did find high overall use of electronic records, used by 91% of our clinicians. And throughout the webinar, you're going to see that we've highlighted some numbers that stood out based on specialty and care setting differences, green being higher than other groups, red being lower than others. So as you can see here, physicians and nurses do report somewhat higher use of electronic records as compared to 85% of AHPs. We also see higher use in hospital settings among 96% of hospital clinicians versus 89% that are practicing in community settings. So overall, we do see that there is high use of electronic records, though not quite universal. So nearly all clinicians in our sample say that they do document patient clinical summaries at their practice. Primarily, we see that they're using just one electronic system to do so, as reported by 2/3 of our sample. However, this means that 1/3 of clinicians are having to use either multiple systems or still using paper only. We saw 18% use multiple electronic systems. 1 in 10 use a hybrid system of both electronic and paper, and 7% are using paper records only. Looking at specific types of clinicians, we do see that GPs are more likely than others to be using just one electronic system and less likely than others to be using a hybrid system. So overall, what we're seeing here appears to be some inconsistencies with respect to record keeping across care settings. So we also assessed the level of access that clinicians have to specific patient information. A majority of clinicians do say that they usually have access to most types. We can see that 7 in 10 or more typically have access to medication summaries, allergies and intolerances, history of illness, diagnostic results, problem list, and procedures and surgical history. And while clinicians do report fairly high access to most types of information, we see consistently across nearly all types of information that roughly 1/4 of clinicians say they currently do not have access, but would want to access this information for the care of their patients. So what we're seeing is gaps in accessibility where some clinicians need, but don't actually have access to certain information. It is, though, interesting to see that there are relatively few clinicians who actually say that they don't need access to each type of information, particularly those that are listed kind of in that top half of the list. We're seeing that, the vast majority, nearly all, seem to believe that they do need to access this information in order to provide care. And we did find that there were some differences in terms of the level of access to patient information based on different clinician types. So as you can see, AHPs tend to report lower access to most types of information listed compared to physicians and nurses. We see specifically specialists report higher access to diagnostic results, while GPs and nurses report higher access to a number of different types, such as vital signs, immunizations, and pregnancy-related information. But now looking at those who don't have access but say that they would like to have access, we do see it's the AHPs who tend to be driving this desire for greater access, more so than we're seeing with physicians and nurses, who we just saw do typically have greater access compared to the AHPs. So when it comes to specific types of information, we see that AHPs are particularly more likely than other clinicians to want access to summaries from specialist care, problem lists, vital signs, procedure and surgical histories, discharge notes, history of illness, diagnostic results, allergies and intolerance, and medication history. So while we see that the AHPs are less likely than other clinicians to have access, they do generally feel that they still need this information to provide care. Regardless, though, across all types of clinicians, including the physicians and nurses, we do see that there is a fairly sizable group who are not able to access patient information that they feel that they need. So we wanted to see what the exchange of patient information between care settings currently looks like. So in the past 12 months, we see that there has been a lot of sharing of patient information between providers. Half of clinicians working in community settings say that they've sent information to hospital, and just over half, 57%, say that they've received it from hospital. Say that they've sent and received patient information We're also seeing a lot of exchange happening among clinicians working in hospital settings. Most, 85 to 87%, sent or received information to and from community providers. And similar to what we saw with community providers, there's also a lot of exchange within hospital settings, with over 80% exchanging patient information with other hospital providers. So evidently, there is a lot of exchange of patient information happening across providers and settings, further establishing the need for improved interoperability. Right. So we asked clinicians what key external patient information that they specifically have access to. So this is thinking of information that they obtain from other providers. So among clinicians with access to each of these types of information, we do see a majority say that the information is usually delivered directly into their practice system. Particularly when it comes to diagnostic results and medication summaries, we see that about 7 in 10 clinicians usually access this directly from their practice system. However, you can see that many clinicians typically receive this information from multiple sources, meaning it's not consistently received through one single source or consistently received through their electronic system. So while a majority do receive information electronically, some are still usually obtaining this information by fax and paper chart and mail as well. So looking specifically at fax, we see that diagnostic results, summary from specialist care, procedures and surgical history, as well as discharge notes, are often received through fax for about 2 in 5 clinicians. And nearly a quarter say that they typically access diagnostic results, summary of specialist care, discharge notes, allergies and intolerances, and problem lists by paper chart or mail as well. So while in general, we are seeing that there's some level of interoperability in terms of exchanging information between electronic systems, there's still a lot of variation and inconsistency in how this information is obtained by clinicians. So we're seeing that it appears multiple sources may need to be monitored when they're looking for external patient information. So next, we asked about how frequently they usually receive summaries of external care. So meaning the care that their patients receive from other clinicians outside of their practice. We found overall that 18% of clinicians say that they always have access to this information. Fewer among specialists and nurses, with only 12% saying that they're always provided this. GPs tend to be kept more informed than others, as may be expected. However, overall, we see that most clinicians, 82%, say that they cannot always access summaries of external care. And in fact, we actually see that just over 1 in 10 say that they rarely or never do. So among those who do typically receive summaries of external care, we asked how they usually receive them. And quite similar to what we saw in terms of accessing patient information from external systems, we see that these summaries are also received in various formats, with many clinicians usually obtaining this information from multiple sources. We can see that about 2/3 receive it electronically, more so among GPs and nurses. However, this means that 1/3 of all clinicians cannot access these summaries through their electronic system. About 2 in 5 receive it via fax, and this includes a majority, 54% of specialists, who we have found have actually remained quite reliant on fax when it comes to receiving patient information. 1/3 report that they receive it typically by email, and when looking specifically at AHPs, we see that email is a very common source for them, while they're much less likely to be using fax compared to other clinicians. And we see that paper still remains a prevalent source, with 1/3 commonly receiving these summaries by paper, more so among specialists and nurses than what we see with GPs and AHPs. And when it comes to the practice settings, we see that those working in community settings are more likely than hospital providers to say that they receive it by email, while comparatively those in hospital are more likely to receive it by paper, more so from other providers versus from the patients themselves. So as we've seen, it appears that many clinicians must access multiple sources when looking for external patient information. So it was important to understand exactly how much impact this has on their time. So we asked clinicians how much more time beyond what they feel should be spent in a typical day is actually spent looking for patient information outside of their own practice system. And while time spent varies, we see on average, clinicians believe that they're wasting nearly 40 minutes of time per day. So of course, this daily impact on time can add up to several hours wasted per week by each clinician just trying to find external patient information. So we wanted to assess perceptions among clinicians in terms of benefits and outcomes of further improving interoperability. As Waldo had mentioned, for respondents, we defined interoperability as the seamless exchange or sharing of specific patient information between healthcare providers across care settings. And improved interoperability relates to their ability to access and exchange structured patient information from their practice systems. As you can see, overall, clinicians very clearly agree that increasing interoperability would be highly beneficial, particularly when it comes to patient care. We found about 9 in 10 clinicians agree it would enable safer patient care as they have more complete, timely, and accurate information. It would enable better experience for patients and improve the quality of care that clinicians can provide. They also see benefits when it comes to efficiencies in their practice. So nearly 9 in 10 agree that it would reduce redundant administrative tasks such as data entry, as well as improve their ability to collaborate and coordinate care with the other providers outside of their practice, which of course would ultimately lead to better care provided to their patients. So we see that clinicians do recognize the benefits when it comes to patient care as well as the patient experience and potential improvements within their own practice related to efficiencies and collaboration with other providers. So while clinicians evidently recognize the benefits of continuing to improve interoperability, we found there are certain challenges or barriers that they experience or perceive when it comes to making changes related to increasing interoperability. The lack of universal adoption of exchange standards when it comes to sharing patient information is seen to be the greatest barrier. It's reported as a major or moderate barrier by a majority of clinicians, 60%, and seen as a major barrier for over a quarter. In addition, we found that half of clinicians believe that the lack of incentive when it comes to improving interoperability is also a considerable barrier. Other key barriers tend to relate more so to the technological aspects associated with improving interoperability. So looking specifically at, lacking capabilities to integrate systems, costs associated with technology updates, and the focus on technological solutions versus looking specifically at their practice needs. These are considered major or moderate barriers for about half of clinicians as well. We also see that challenges related to integrating electronic systems into their practice's workflow, poor usability of electronic systems, and requiring technical support are barriers for some clinicians as well. So it is important to note that while these barriers may vary among clinicians, we found overall that 98% of clinicians reported at least one of these to be a moderate or major barrier. So nearly all are reporting some sort of challenge when it comes to improving interoperability. And we did find some differences by clinician type when it comes to perception of these barriers. As you can see, a greater proportion of specialists do report most of these as being moderate or major barriers as compared to other clinicians. Specifically, more specialists experience barriers when it comes to the lack of universal adoption of exchange standards, lack of incentives, issues integrating with external systems, affordability of technology upgrades, and the perception that interoperability is too technology driven. We also see that physicians overall, so both GPs and specialists, tend to believe they need some more technical support than what we're seeing with nurses and AHPs. So there are some differences in these perceptions by clinician type, though overall, as I mentioned, nearly all clinicians do say that they see some considerable barrier with respect to improving interoperability that will need to be overcome.
Thank you, Stephanie, for those really interesting findings. I hope all of you found it interesting. We're gonna start the Q&A piece, so I'll moderate the questions that are coming in. And if I encourage you to type in your questions in the Q&A box or the chat box, and we can pose them to either Waldo or Stephanie. But before we get into it, I think I'm gonna pass it over to Waldo just to give us a summary of everything that we've heard before we jump into questions.
Okay, thank you, Sakirta. Now, as we are heading towards the Q&A and the end of the presentation, there is a couple of things that I'd like you to walk away with. Number one, 90% of Canadian clinicians are practicing in the digital environment. And on top of that, the majority can access some pieces of key patient information like medication summaries and diagnostic results. And not to toot my own horn, this is thanks to InfoWay's past investment, right? Number two, there is a relatively big chunk of time that is wasted searching for patient information externally, 40 minutes. So as a patient, you might ask, if clinicians are spending 40 minutes beyond what they should spend searching for information, what is left for direct patient care? But me as a quantitative economist, if I were to put a dollar value on this and extrapolate it, it would be a huge financial loss for the healthcare system. And lastly, clinicians overwhelmingly see value in improved interoperability to Canadians and their health. So what about you? And this leads me to ask the last polling question. So I'm going to launch the question. So it's gonna be our last question. Now that you know a little bit more about interoperability in the Canadian healthcare landscape, how much of a priority is improving interoperability in our healthcare system? Is it low, medium, or high? I'll give you 10 seconds and I'll get back with the results. Okay, I think the results are in. Still, people are still answering the question. Okay, let me share the results. The good news is, for the majority of you, 87%, improving interoperability in the healthcare system is a high priority. And this is consistent with what we found from another survey, which was the qualitative arm of the interoperability study, when we asked stakeholders like leaders, representatives from the government, vendors, they said that interoperability is a high priority. So I will stop there and turn it over to Sukyurta for the Q&A.
Great, thank you, Waldo. And again, thank you, Waldo and Stephanie, for sharing this interesting piece of research with us. I've seen some comments come in and some questions as well, so I'll do my best to moderate, and but either of you feel free to jump in with the answers where you feel you can add some comments. I'll start with a more technical question about the survey data. The question is, can we break down some of this data by geographic regions? We've got people, for example, can we see an Ontario cut? So Stephanie or Waldo, either of you want to take that?
Stephanie, you want to go first?
Sure. So I know in the report, I believe you'll be releasing that, and we do have, a lot of information specifically looking at the different provinces and how they compare. We didn't see a ton that really stood out in terms of differences by the province, but we did see a few kind of general trends. So one thing that kind of stood out to us was in Eastern Canada, so Quebec and the Atlantic provinces, we saw, somewhat fewer that document patient information electronically, and more that use more of a hybrid system. We also saw Quebec was specifically less likely to receive the summaries of external care electronically, and both Atlantic and Quebec were more likely to be receiving it by paper. We saw some lower access among this group when it comes to specific patient information, but as we saw with the AHPs, even though they have lower access, they still felt that they need this information to provide care. And we also saw some, lower satisfaction with referral systems and efficiencies when it comes to receiving patient information with this specific group. Another province that we saw stand out a little bit was Alberta. In a couple kind of questions that we asked, they tended to have higher use of electronic records than other regions. And they also had the highest proportion that documents in one electronic system only. But I believe we will have, most of the questions showing the regional breakdown when the full report is released.
Great. Thank you, Stephanie. Waldo, anything to add, or should we move on to the next question?
I think we can move on to the next question, but before we do that, one thing that I would like to add is in terms of I know we've had this question around slicing and dicing by region, but within a province, whether we are able to do some breakdowns. For example, for Ontario, we collected a sample of 336. So we should be able to slice and dice within for some provinces, we should be able to do that. But we have a limited, we have a variable sample for some regions, so we won't be able to do that.
Great. This is a question that's come up for us as we were looking at these findings as well. So I'll throw it to you, Waldo. For how clinicians receive patient information, we've got a significant proportion that are using fax. And the question is, do you think the e-fax is being captured in the fax, or is it being captured elsewhere in what we consider to be electronic?
That is an excellent question. I mean, first of all, for e-fax, we didn't ask specifically the question around e-fax, but we suspect that when we ask the question around the methods of receiving patient information, people might factor in or might take into consideration e-fax when they answer that we are exchanging information electronically. But we didn't ask the question specifically. We didn't ask whether you are using fax or e-fax. We didn't make this differentiation in the survey, but we suspect that some people are using e-fax and they think that exchanging information using e-fax is electronic exchange. So that's one way to answer this question.
Great. Another question here for, I guess, if either of you want to tackle it. Were we able to identify any specific quality related measures as it relating to health information exchange?
For quality, we collect a bunch of interoperability related indicators. We have a question around volume. It's not the best indicator for volume because interoperability is about the quality of information that is being exchanged, the volume of information, and whether the information is usable by the healthcare providers that are receiving. I don't recall we collected information on quality. Stephanie, you can correct me if I'm wrong.
No, I think you're right.
Yeah, but for volume, we did ask one question to get a sense because this is one of interoperability related indicator, volume of information that is being exchanged.
That's great. Yeah, I think it was kind of out of scope for this piece, but I think this gave us a lot of a sense of the landscape, but I think it also gave us a sense that there's a lot of additional work to be done for us to explore into specific areas and I see a lot of comments also coming here about the patient aspect of this, and we really want to illustrate that this was a small component of us trying to get a sense of what the information exchange landscape is like, and we are doing some further work to we're continuing to conduct research and evaluation in this space and looking to our partners that are also doing work in this space to generate further evidence. And one of the things we're doing right now is we're embarking on our national survey of Canadians, where we will be exploring some aspects of interoperability from the patient perspective. And that might help us down the road with some additional quality related work as well. There is a comment here about will we share these slides afterwards? We will make the recording available, and the report from these findings will be made available towards the mid to late October. So all of you that have joined will definitely send out a message when that becomes available and make sure that you've got access to those full results. We've got a question about some of I get the question for Stephanie about what is it like surveying clinicians right now? Can you tell us a little bit about how much can we draw from this data? You've given us the sense that this is nationally representative. We've done some of the checks and balances to make sure that we're talking about a representative population, but is there any other insights in terms of how much we should take away from these findings from a methodological perspective?
Yeah, so as I mentioned, these clinicians, they're recruited from a panel of healthcare providers. So these are respondents that have already signed up to receive invitations to participate in studies such as this. The panels are, invitation only. So we make sure that we are going out to actual clinicians, and then they're also all evaluated based on their quality. So the quality that they're giving to these types of studies. So for this specific study, we roughly 36,000 clinicians were reached out to, either by phone or email, asking them to participate. And as mentioned, we did have really good regional representation, and data was weighted according to region based on specialty to make sure that we did have a representative sample. And then going just beyond the region, we also saw that, the demographics that we had kind of touched on are actually very reflective of what we see in the population as well. Looking at gender, it varies quite a bit within each of these specialties, but we saw that that was also reflected in our sample. And we also found, the age of respondents is very reflective in what we see in CHI population estimates as well. So in terms of the sample composition, we do find that, it's very reflective of what we see in the Canadian population, but you do want to keep in mind, these findings that we're presenting, they're a snapshot of clinician perspectives, and we are, of course, relying on clinician perceptions when it comes to the state of interoperability for these results.
Great, thank you. We've got, there are a lot of questions and comments coming in, and I'm doing my best to kind of bring forward things that are kind of common and for discussion. One of we've got a question here about the incentive finding, and wondering if we can provide more clarification on how the question was worded. Is the barrier result indicating that clinicians believe they should be compensated for being interoperable? But Stephanie, do you want to just provide some clarification maybe, or Waldo, on that specific, how we worded it, and what to take away from that finding?
Yeah, so it was a agreement or a scale in terms of being not a barrier, minor barrier, moderate barrier, or major barrier. And the wording for that specific one, let me just see where it is. There is a lack of incentive for the exchange of structured patient health information. So it was kind of a general statement.
Yeah, and one thing that I would like to add to this, it was a very general question. We asked whether there is a lack of incentive, and one thing that I think was missing in this was whether it was financial incentives or other types of incentive. Because when we asked the question, it was a very broad question. So I think in the future, one way to improve that is to ask the question and ask people whether to be more specific around the incentive, whether it is financial incentive or other types of incentive.
Great. Thank you, Waldo. Maybe I'll ask Waldo. I'll ask you a bit of there's a few different themes that I'm seeing in the questions, and in the interest of time, I'm going to ask you a question about. So this research, you led jointly with Stephanie. Can you tell us a little bit about trying to evaluate interoperability from the clinician perspective? There's a lot of questions we're getting about, like, did we evaluate this aspect, the other, standardized, like structured information? How is there a desire for clinicians to have that, even details about incentives? Can you maybe give us insights for those of us that kind of wear more of an evaluation hat on, maybe the challenges and maybe the ease with conducting a study like this, or what's helpful, what can we take away from it, what do we do in a future iteration of trying to kind of dive deeper into this area? That's a loaded question, Waldo.
Yeah,
I know you can handle it.
I'm going to try to provide an answer to this question, but it's a very question. I think I can take this question and write a whole thesis about it. First of all, we have to agree that interoperability is a very convoluted concept, and it's not only about sharing of information, like information flowing from one healthcare provider to another. We have other aspects of interoperability. I've seen I saw a question around patient centricity. I think this is one of the aspects that we can capture in this survey. Probably we will capture this later in our Canadian Digital Health Survey, which is an annual survey on Canadian citizens. Now, back to the question. So we have interoperability. What we were able to collect is the exchange of information from one provider to another. But what is missing? One thing that is missing is, I know we collected information on documentation. So we have a couple of questions around documentation, but because before you can even exchange the information or accessing the information, you have to be able to make it available. So documentation is an important aspect of interoperability. Now, when we talk about documentation, another important part is how we capture the information, because we don't want to capture, we want the information to be captured in a structured way so it is interoperable, right? So the other health provider that is receiving the information, they're not only receiving information, they are receiving information that they can use to make decisions. That's another aspect of interoperability. Someone mentioned quality. We didn't collect information on quality. And in terms of lessons learned from this survey, number one is we've seen several clinicians, I mean, even the bulk of the clinicians we surveyed, they do have access to digital infrastructure, but accessing the digital infrastructure does not necessarily lead to interoperability, because you can have access to EMR HISs, PSMS. You can have access to electronic record systems, but you are not connected. And this is where it is important, because remember that I mentioned interoperability is about the 3 C's: connection, collaboration, and communication. So I don't know if I answered this question, but this is what I at least learned from the survey. So moving forward, what I think we can improve in terms of the questions, we probably need to collect more indicators around interoperability, because what we've collected, it was the flow of information from providers to providers. We need information around quality. We want more information about documentation, how the data are captured by healthcare providers, and then more information around the healthcare infrastructure that they have available that will support interoperability, because you can have an EMR, you can have multiple EMRs in your care setting, but that doesn't mean that you are interoperable. You can communicate with other people. What if the solutions, they don't communicate to each other? You see what I mean? And I think this is one of the things that we observe in other surveys, having access to multiple systems. And it was part of this survey. Having access to multiple systems, like you have multiple EMRs that you can use to retrieve patient information, is also a problem, right? So back to you. I know I've talked a lot. I don't know.
No, I asked you a loaded question, and I think maybe like just to sum it up, it's that this was our sort of starting to scratch the surface on how to evaluate some of this aspects, and the lack of sort of the evidence in this area as well. So we're trying to generate it. We'd love to hear from those of you that are also generating evidence that can help us kind of give us more insights around this topic. And we look forward to doing more work in this area and generating additional evidence, and as well as in other areas. I know there's some questions that have come up about standards, about change management, and I want to recognize that all of the great participation we've had at this webinar definitely illustrates the importance of this topic to a lot of our stakeholders, a lot of us in the healthcare system. So I want to make sure that we appreciate that, and a lot of these comments we will be taking it back because they apply to beyond just the performance analytics team, the evaluation hat that a lot of us those of us on the table right now are wearing. And we encourage you to kind of stay tuned to some of the work that we're doing there. We're continuing to evaluate in this space, generate additional knowledge in this space. And so there are different aspects that you're asking about that will be where InfoWay will be driving forward some of these conversations. We've got some additional research findings that'll be coming. These findings will be published later this month. Some additional work around digital health leaders' perspective, electronic clinical communication, privacy. There's lots of related work that is going to be coming out from InfoWay, and you can kind of stay connected, and we'll make sure we share those findings when they're made, when they're available. We are at 2 o'clock, so thank you everybody for joining. Thank you to our panelists, and we're excited that we've generated interest, and stay tuned for future conversations on this topic. Thank you, everyone.
Thank you. Take care.
Thank you. Bye.